It's a great pleasure to be asked to speak about one of my favourite topics, safer surgery in glaucoma. These are my disclosures. This is going to be a very short talk, just about 5 minutes long, and I'd like to start by talking about that fundamental premise on which all glaucoma surgery is based: sequence and timing, getting the right sequence of operations in the right order at the right time. So let's consider this case. We've got a 27-year-old male with pressures of 40 millimeters mercury in each eye on maximum therapy and very advanced, potentially blinding glaucoma. This is juvenile open angle glaucoma and needs a specific surgical management. The gold standard surgical management for this patient would be trabeculectomy plus anti-scarring mitomycin C, which would give every opportunity to prevent blindness in this patient's life. And the use of trabeculectomy in this particular scenario is supported by a wealth of evidence. So here's Jim Kerwin and Alistair Lockwood. I was very lucky to be involved with them in this wonderful study, Trabeculectomy in the 21st Century, which came out of the UK and reset the bar for glaucoma filtration surgery. And then in a more specialist area, I was part of the team together with Pavi Agarwal, looking at the long-term outcomes of trabeculectomy with mitomycin C in a specific ethnic group, a very challenging ethnic group, African Caribbean patients, where there's a lot of post-operative scarring potentially. So when you've got a gold standard in a certain situation, this is where a MIGS operation, for example, iStent technology, would not be the optimum way forward. The key is to know when MIGS surgery, and in particular, we're talking today about iStent technology, where is this appropriate in the surgical journey of glaucoma patients? And this is some product information, but actually these slides are important. And if you're going to be putting devices into patients, it's very important indeed that you've read all the product information and you've read the official indications. I'm going to talk to you about my personal views, but always start from the standpoint of knowing the official indications. So in my opinion, I think you can use iStent technology for intraocular pressure control in early to moderate disease. So for example, where you've got dual or triple glaucoma therapy and an angle that is suitable for iStent insertion. However, I'd also like to raise some specialist situations where I think iStent technology can be very useful. This is just some of the basic design features of the new iStent Inject W, where there's a wider flange which makes insertion into the correct place much easier. And I'm sure everybody understands the technology very well. It's a prerequisite for actually starting this journey. And another prerequisite for this journey is to understand angle anatomy. That's why you can't just have any surgeon start implanting stents. You've really got to understand your angles. You've got to be a proficient gonioscopist, and you've got to practice that skill as much as possible in clinic. That's what glaucoma surgeons do. And you'll then know that there's huge variation in angle anatomy. Just the distance between Schwalbe's line and the scleral spur can vary dramatically between patient to patient, and there are all kinds of angles. Remember, when you grade an angle, always grade from anterior to posterior, and that way you'll always get the correct location of the pigmented trabecular meshwork. And this is important because gonioscopy is going to tell you about the surgeon's enemy. And a real enemy of any glaucoma surgeon is a brittle drainage angle. I coined this term many years ago, and for me, a brittle drainage angle is one that has reduced functional reserve and is therefore prone to intraocular pressure instability with sudden, unpredictable, intermittent, high intraocular pressure spikes. And so this is important when we operate because it helps decide what choice of operation, how we consent the patient, what steroids and frequency we're going to use post-op, when we see the patient even, what drugs we use, do we stop prostaglandin analogs, do we start acetazolamide? These are very important issues. And combined with the brittle angle, we've got another surgeon's enemy in glaucoma, the disc at risk. So the disc that is at risk of wipeout. And we know these kind of eyes, they're the eyes with reduced acuity, advanced field loss that goes into fixation, very high brittle pressures, patients who are systemically unwell. These are the patients we need to worry about. You've always got to balance the brittle angle and the risk of wipeouts. And so it's interesting, but some of these new technologies have really helped us. If I go back 20 years to when we were operating, doing phaco on eyes with brittle angles, sometimes it was a lottery whether you'd have a pressure spike of 40 on the first post-operative day, whether that pressure spike would last. But now we have these wonderful technologies that enable us to mitigate that early high pressure spike. And so for me, the role of a technology such as iStent is in early to moderate glaucoma disease, particularly where you want to mitigate against pressure spikes. So let's just take an 80-year-old lady with moderate glaucoma in both eyes. You could reduce the polypharmacy, reduce the ocular surface disease, reduce the drug toxicity, and potentially reduce the number of follow-ups needed by inserting stents at the time of your cataract surgery. These things are very important, particularly in a COVID era. Another indication, the second indication there, is where you've got significant or acute ocular surface disease and you need surgery, because you're going to allow the ocular surface time to recover. And sometimes the ocular surface doesn't need much time to recover, to re-establish itself. Then you've got your moderate to high risk cataract surgery. And I would almost challenge everybody to say, you know what, you should really be thinking about augmenting phaco with a technology, for example, such as iStent, in this moderate to high risk surgery where you don't want pressure spikes, pigment dispersion syndrome, pseudoexfoliation, etc. And finally, in advanced disease, this is a more specialist area. It's off license, but you can, for example, augment tube surgery with stents in place, particularly if you're anticipating a very high post-op pressure spike with a tight tube insertion. So I'm going to end with a very simple case presentation. These are real cases that were sent to me for second opinions. On the first case, 63-year-old male where megalocornea was missed, therefore the pigment dispersion syndrome was missed, and when the patient had a phaco, they got a pressure spike of 50 that never came down, and the patient needed 4 further glaucoma filtration surgery operations. The second case, operated on by a colleague of mine, Mr. Imran Masood, 73-year-old male with pigment dispersion syndrome and quite bad pigmentary glaucoma, deep set eyes, tight orbits, bilateral phaco plus iStent, pressures of 11 afterwards in both eyes. The difference there, the difference to the patient, to the journey, to the economics of this is something worth thinking about. So for me, safer surgery, the more tools we have, the safer we are, but we need to use those tools very wisely. I hope this very short talk has given you a few things to think about. And we just finished with 2 commercial slides. So these are some of the values of iStent technology. And really on this whole slide, I would say very much think about the cost savings to our patients in the NHS by preventing complications. I think we can make some fairly persuasive cases here. And finally, be alert to the fact that this is technology that has a very good track record. For those of you who are interested, we run a regular iStent masterclass, and it is a superb educational resource run by Glaukos. Thank you very much.